Hi, my name is Mark Brady. I'm a community pharmacist in Ontario, Canada, and I want to share with you some information about how you can reduce your risk of cardiovascular disease. In particular, I'm going to focus on things beyond just lowering your LDL cholesterol, your bad cholesterol. All right, so why am I here? Why am I doing this? Well, back in 2013, my family doctor told me that I had high triglycerides and low HDL, which was an indication for prescribing a family of drugs called fibrates. He asked me if I wanted one, with the caveat that we both knew that taking a fibrate would make my labs look better, but there was no evidence it was going to make me live any longer. So I decided to start doing some more research and find out what exactly it meant to have high triglycerides and low HDL. So when I looked at my cardiovascular risk, I had no risk factors. I did not have high blood pressure. Didn't have high cholesterol. I was not obese. Didn't have high blood pressure. Nothing that would indicate that I was at risk. Although I did have an uncle who died young of a heart attack, and my father had triple bypass surgery in his 60s. But beyond that, everything looked normal. So I had just had my first child. My wife was pregnant with our second, and I decided that I had to have more information. I wanted to know how at risk I was. I talked to my doctor about getting what's called a coronary artery calcium scan, which is a very specific high tech scan they do of the arteries of your heart and check for any signs of calcium. Calcium becomes a lining of the arteries when you've got plaque in there and your body is trying to protect the plaque by putting this calcium or bone-like substance over top of the plaque to keep it stable and make sure it stays there. Problem is that if it breaks loose, it goes downstream and causes a heart attack. So with this coronary artery calcium scan, they can actually take a look and see how much calcium you've got in your arteries. I was referred to a cardiologist. Cardiologist did not want to give me this coronary artery calcium scan. He thought it was a waste of time and resources. I was very well prepared. I didn't take no for an answer. It took quite a while, but I finally got him to agree to order this test. As I left his office, the last thing he said was, I guarantee you're going to get a score of 0, and this will have been a waste of time and resources. Well, the test score came back, and I was in the 80th percentile for people of my age, gender, and race, which meant that my arteries were worse than 80% of the people my age, gender, and race. And in spite of the fact I did not have any apparent risk factors for cardiovascular disease. So this meant that it was primarily hereditary. I further research. I discovered there's a lab test called lipoprotein A, more commonly called LP little a. At the time, it was not covered by the Ontario lab tests, so I paid $30, had this test done, and I found out that I had a very high risk marker in that LP little a test, which I already knew because it was the only explanation I could come up with why I had no risk factors for cardiovascular disease, and yet my coronary artery calcium was pretty bad. All right, so as I started researching on the internet what was high triglycerides and low HDL, I came across a Japanese trial called JELIS. And in that study, they looked at about 16,000 Japanese people. It was not a particularly high triglyceride group. They were not high risk people, but it was over a long period of time. It had a lot of patients in it. And they were looking at a chemical called EPA. EPA is an omega-3 fatty acid. It's already in every single cell of your body. And so it comes from fish. And the Japanese population, they eat a lot of fish, so they have a relatively high level of this EPA in their system already. When they looked at the results of the trial, what they found was that there was a 19% reduction in cardiovascular risk. And then when they look specifically at the high triglyceride, low HDL subgroup, they found that there was a 53% reduction in cardiovascular risk. So that's right here. Okay, so there was a this is the control arm, the placebo, and this was the people that were taking a prescription version of EPA, the omega-3. Now, as I looked at the data further, I realized that there was, a significant difference between the EPA, the omega-3 fatty acid, and AA, which is arachidonic acid, an omega-6 fatty acid. And there's a correlation between this ratio and how effective the drug was. Now, there was another study that was completed. A pharmacy company did this study. It took 7 years. Average duration that the patient was in the treatment was 5 years, and it was released in 2018. It was called Reduce It. When they looked at that subpopulation that I was looking into of high triglycerides and low HDL, they found a 40% reduction in risk. So up here you'll see a RR 0.6, and that's risk reduction, where they look at the hazard ratio and essentially just translate to 0.60 hazard ratio is a 40% reduction in cardiovascular risk. And this was the number of events that happened in that population that was in the trial on the placebo versus the patients that were in the treatment group, which was a prescription drug called Vascepa, which is Icosapent Ethyl is the chemical name. Icosapent Ethyl is a modified EPA molecule so that the EPA can be absolutely purified, as well as preventing oxidation as it's encapsulated into the pharmaceutical product. And it's not like the dietary supplements that you can buy in the front of a pharmacy, where there is EPA, DHA mixtures available without a prescription. My concern there is that it's predominantly oxidized EPA, and oxidized EPA may not be just less beneficial, it may actually be harmful. So, while I was doing all this research on cardiovascular disease, my wife was trying all kinds of different diets to lose weight after having a baby. And we were eating all kinds of meals that didn't look like food. It didn't taste like food. It was not enjoyable. And yet she wasn't losing weight. I wasn't losing weight. And then all of a sudden, after a couple months, I noticed she lost 20 pounds. And I asked her, how did you do it? Because we've been eating good tasting food, and everything has been like normal. And she told me that her dietitian, her nutritionist, her trainer at the gym had all told her about intermittent fasting, as well as a low carb, high fat diet, and that was what she was doing that allowed her to lose so much weight in a short period of time. So just like with this high triglyceride and low HDL, I wanted to know more. I wanted to know why and understand it. So I started doing a lot of research on how the eating habits of man have changed in the last 50,000 years. And when I looked at the diet of, let's say, 10,000 years ago versus now, I noticed there was a lot of significant changes that have only happened recently. All right, so I tried the diet myself, and I ended up losing 20 pounds as well in about 2 months. So I was convinced there was something here to research further. All right, so why is intermittent fasting and low carb so effective? Well, it mimics the human diet for the past 50,000 years. So as our bodies have evolved, we've evolved to suit the diet, the way that we eat and what we're eating. For the longest period of time, humans ate when food was available and didn't eat when there was no food available. Our bodies became very efficient at storing calories in the fat when the food was available, so that when there was no food, we could access the calories in the fat and use that for energy. So the diets back then were mainly protein and fat. There wasn't a lot of carbohydrates in the diet, and so they were eating animal meat, animal fat, nuts, fruits, well, fruits in the fruit season, which has the carbohydrates and so forth. But it was a very basic diet. So When did all of this change? Well, the answer is that back in the 1960s and 70s was the industrialization of the food industry, where they moved more toward providing more and more food in a ready-to-eat or easily prepared products that they could sell in grocery stores. Right? So when they were making these products and they wanted to have a high protein content, they would add soy for protein. And when they wanted to have a large carbohydrate content, they would add corn. Now, if you think back, we've all probably seen and heard about the food pyramid and how we should be eating. And at the base of the food pyramid, it's carbohydrates. And that food pyramid, as I've researched it, had very little science behind it and was predominantly produced by the food industry. So, why did this all happen? Well, at the same time, scientists in the US discovered a way to convert corn into a high fructose corn syrup, okay, HFCS. And this stuff is far more potent as far as sweetness, and it is much cheaper to produce. It also meant that they could reduce their reliance on the Caribbean sugar cane imports as a source of sweetening their food. It created a massive amount of jobs in the U.S. Agricultural Department as their farms were starting to grow and more corn and as well soy for the protein content. And in this high fructose corn syrup, now let's go back to a little bit of basic chemistry here. Sugar, cane sugar, or table sugar, is a connection of a glucose molecule and a fructose molecule together. Now, every cell in your body can absorb and process glucose. Only your liver can process fructose. But never in our history has our bodies, our livers, been required to process so much fructose. The amount of fructose we started to consume jumped astronomically in a very short period of time, and our bodies weren't able to adapt. So if you look at these two charts here, I'll show you that this is the obesity population and how right there after the 60s you started to see a significant rise in obesity. And over here we have the free fructose in the diet as well as the high fructose corn syrup. And both of these just exploded in the mid 70s, late 70s. Now, if we look over to here, now this is from the National Institute of Health, and it was the statistics on the rate of type 2 diabetes over time. And you'll see that it just started to take off, and diabetes has become an epidemic. So what happened around the same time? Well, this is a graph of soybean consumption over time. And here you'll see this is in the late 60s where soybeans were discovered as an inexpensive source of protein. And the use just exploded. All right. So this graph here shows you that over time, the concentration of omega-6s. Now remember, soy and corn are both omega-6 fatty acids. All right. So the concentration in the fat tissue of these omega-6 fatty acids has just been going up and up and up. All right. That's omega-6 over time. This graph here shows you coronary heart disease mortality, and this is the tissue levels of omega-6. Now down here you have Greenland, Japan, the Quebec Cree, populations that eat a lot of fish. And up here you have the US population and the rest of the world that are eating a lot more of the omega-6s, soy, corn, and so forth. So as tissue levels of omega-6 increase, you see a linear increase in cardiovascular disease. All right, so remember, omega-6s are soy and corn. Now, just to give you a little idea what this means, and this would be more for the other pharmacists that might be listening to this or medical professionals, the name omega-6 or omega-3 fatty acids Well, if you know, in the alpha to the omega, omega is the final letter in the alphabet. And so omega 9 means that this double bond first appears on the ninth carbon. For the omega 3 fatty acids like alpha linoleic acid, the first double bond starts on the third carbon. So these are different omega 3 fatty acids because they all have the first double bond starting at the third carbon, and that's alpha linoleic acid, which is derived from plants, and EPA and DHA, and these two are derived from fish. All right, this is what that actually looks like. Okay, this is a picture of the cell membrane. It's called a lipid bilayer because on the outside here is a hydrophilic or water-friendly surface, and the inside here is a hydrophobic or a oily or does not mix with water. Okay, and so the phospholipid head and these fatty acid chains that hang down. In this diagram here, the red part is the DHA fatty acid attached to the phospholipid in the cell membrane, and down here you'll have the green EPA molecules, and you'll see they're the same thing, but a DHA molecule is a little bit longer than EPA, and that's why you see DHA curls up and doesn't quite sit linearly in the lipid bilayer, whereas the EPA sits nice and comfortably in there. Now, the other place that you find EPA is in triglycerides. Tri meaning three, three molecules attached to a glycerol molecule. So here's your glycerol, and then you have three fatty acid chains that hang off the triglyceride that make a triglyceride. And so what you can have is one or two or whatever of these being an EPA molecule, a DHA molecule, arachidonic acid. But so where you find omega 3s in your body is in the cell membranes, every single cell of your body, as well as in the triglycerides, which is how your body stores fat. Okay, so omega 3s, they come from fish and seafood, and that would be the EPA molecules. You also get it coming from nuts and seeds, but that's the alpha linoleic acid that I mentioned a while ago. And alpha linoleic acid is an omega 3 fatty acid, but it cannot be converted into EPA or DHA. Right? You also get plant oils, so flax seeds, soybean oil, canola oil. These are omega 3 ALA, or alpha linoleic acid, but there is no significant amounts of EPA and DHA. EPA and DHA are critical to the proper functioning of the human body, of the cells, and you need to get this from fish. Your body only has the ability to produce a very small amount. Now, omega-6 fatty acids, which also play an important role in the human body, they come from soybeans, corn, sunflower oil, nuts and seeds, and so forth. And these are where we have had a massive increase in the consumption in a relatively short period of time when you look at the time frame of how long humans have been around and how our bodies have evolved. So you may see in the grocery store that there are omega-3 enriched eggs. These are enriched with alpha linoleic acid, and alpha linoleic acid is a good chemical to have. It is better than an omega-6, so I think these omega-3 enhanced products are a good thing to consume. They are better than omega-6, but they do nothing to affect the amount of EPA or DHA in your body. So this here is my favorite slide, and it's more for the chemistry people out there. But what we're looking at is that historically, the ratio between the omega-6 and omega-3 in the body has been about 3 to 1, 2 to 1, 3 to 1. And that's been for thousands of years. Now, since the industrialization of the food supply, that ratio has jumped to 20 to 1. even 30 to 1 and 40 to 1 in some populations. So when you look at arachidonic acid as an omega-6 fatty acid, now it gets broken down by enzymes and it produces cytokines, right, which are chemical messengers. And these are known as prostaglandins, thromboxanes, leukotrienes. These are pro-inflammatory cytokines. They are an important part of the body's natural immune response. When there is something foreign, whether it be a bacteria, a virus, a wood sliver in your finger, your body's immune system mounts a attack and destroy kind of inflammatory reaction, and these are the cytokines that lead that part where they kill the bacteria, attack the virus, get rid of the piece of wood. But there is also the omega-3 fatty acids. They use the same enzymes, but they create a different group of prostaglandins, thromboxanes, and leukotrienes. But they also create what's called as E-series resolvins and D-series resolvins. The D-series resolvins come from DHA, and the E-series resolvins come from the EPA. These resolvins create anti-inflammatory molecules, and sorry you can't see it because of my photo here, but it's the other one is pro-resolvins. They help to resolve the inflammation. So if you look at it as the arachidonic acid omega-6s, they are involved in the attack and destroy what is bad or broken. Then the omega-3 system comes in, they clean up the mess, and they repair the damage. So on an enzyme level, what you're doing is you're having the omega-6 arachidonic acid and the omega-3 IPE or EPA or DHA competing at the enzyme to create either a highly inflammatory prostaglandin or a much less inflammatory prostaglandin or a resolvin, which will help to resolve the inflammation. So I'm sure many of you have heard the term cytokine because cytokine storm was in the news all the time back in early 2020 at the beginning of COVID. And the cytokines that they were talking about were the same kind of cytokines that I was reading about when I was doing my research in cardiovascular disease. And what I found interesting was that patients at the highest risk with COVID were cardiovascular disease, obesity, type 2 diabetes, autoimmune, people with chronic inflammatory conditions. So I wrote an email to friends and families to tell them, hey, if you get COVID, it might be helpful to take this prescription drug called Vascepa, which is a very pure form of EPA that's unoxidized and has already shown very good results in preventing cardiovascular disease. So this email I wrote ended up on message boards. I got passed around. There was cardiologists in New York and internists in Hawaii and an ER doc in Vegas who, read my email and told me that it was very interesting and they wanted to encourage me to keep sharing it, and they thought that there was some good logic behind it. So then there was a Dr. Deepak Bhatt, who is the head of cardiology at Harvard and executive director of the Brigham and Women's Hospital's cardiology department, the hospital affiliated with Harvard. He's also the editor of the textbook that is used by medical schools around the world. So this guy is a huge name in cardiovascular disease. Now, he announced that he was going to be presenting a study that looked at the use of this drug Vascepa, which is EPA omega-3 fatty acid, in COVID positive patients, and the trial was being done in Toronto, Canada. So I was not much of a user of Twitter, but half as a joke, I went on Twitter and I sent this doctor a quick message saying, just so you know, I have already figured out that your trial is going to be a success, and this is why. And I attached a copy of the email paper that I had written explaining it. So he replied back, thanks for sharing. And we eventually started exchanging tweets and texts and emails more often, and he was giving me more information about cardiovascular disease as an inflammatory disease, not as a plumbing problem, which is what a lot of people understand cardiovascular disease to be. And we exchanged emails so much. I got to know this gentleman. He's right here. That is Dr. Deepak Bhatt, head of cardiology. And this was his 2020 Twitter version of a Christmas card where he included my picture on that, which was, I have to say, the professional highlight of my life so far. Quite an honor to be recognized by him. He has over 20,000 followers on Twitter. This gentleman is a real legend in cardiology. The CardioLink 9 COVID trial that was held in Toronto was positive, showing a statistically significant improvement in all of the markers they were looking at, which was the FluPro score, the World Health Organization's way of standardizing patient symptoms, as well as an inflammatory biomarker called HSCRP, which measures systemic inflammation. And with that, there was a 25% reduction. There was also a statistically significant reduction in the D-dimer level, which is a marker for clotting, and clotting was a big problem with patients with COVID. And the erythromyte sedimentation rate also statistically significantly improved, and that is another marker of systemic inflammation. CardioLink 9 was a small biomarker study, and so they needed a larger study to back up the biomarker study. This was done with a trial called PREPARE-IT-2, carried out in Argentina with 4,000 COVID positive patients. In this trial, anyone who tested positive could get Icosapent Ethyl and be monitored for their outcomes. They were expecting 30% hospitalization with COVID in the early days. It turned out that there was only an 8% hospitalization. So the number of events weren't high enough to give this trial the statistical power it needed to be considered conclusive evidence, but the evidence was still trending in the right direction. It was still strong. There was a 22% reduction in hospitalizations and death, as well as the FluPro score, which I mentioned earlier, was just barely short of being statistically significant, but still the trial showing that patient symptoms definitely improved. So the message I'm trying to tell you here is that IPE, or Icosapent Ethyl, is really just a very pure unoxidized form of EPA, which is an essential fatty acid. And so essentially, it's just food. This prescription drug is really just food, an oil, a chemical that is already in every single cell of your body. I'd like to call it a nutraceutical. And I'll get into it next, is the clinical data showing how effective this is at reducing cardiovascular disease is really outstanding. All right. So what I'm trying to tell people is that, if you got cardiovascular disease, diabetes, obesity, then, encourage the person to exercise more, eat better, try and reduce the amount of omega-6 fatty acids that are in the diet, although it's extremely hard because they put it in everything. You want to get them to eat a lot more fish, increase their omega-3 intake, because remember, this is a balance between your omega-3 content and your omega-6 content. Now, because of the food industry, our omega-6 content has skyrocketed, and because we eat a lot less fish, our omega-3s have gone down. So your two options to restore balance to your immune system is either eat a lot more omega-3s or a lot less of omega-6s. Either way, if you get your immune system back in balance, a lot of these problems of cardiovascular disease, diabetes, obesity, and so forth will be improved. Now, the reality is most people are not going to take on these large lifestyle changes that are necessary to get your immune system back into a balance. And for those people, the other option is a prescription for Icosapent Ethyl, which is now covered for people with medical coverage through Ontario Drug Benefits, ODB. Um, all right, so now I'm going to get into a little bit of the data of how this drug treats cardiovascular disease. Okay, this is the Canadian Cardiovascular Society's treatment guidelines for patients with known cardiovascular disease. Right, so these are the first of all, they should be put on a statin. All right, so the people that should be on a statin are people whose LDL or bad cholesterol is over 5, or if they have diabetes, and one of the listed risk factors, which is almost all diabetics. And in the third column here is anybody with known cardiovascular disease. So that's, if you've had a heart attack, angina, chest pain, if you've had a stroke, transient ischemic attacks, any of these things, that is known history of cardiovascular disease. Okay, so first thing is make sure that the patient is on the maximum dose or the maximum tolerated dose of a statin. So the most common ones are Lipitor or Crestor. And if you can't tolerate the full dose, take as much as you can. And like I said earlier, even the smallest dose, which would be Crestor 5 milligrams, if you take one tablet 3 times a week, it's a very, very low amount, it will still significantly reduce your bad cholesterol. I'm saying 40 to 50%. So once you're on that statin, if your LDL cholesterol is still over 1.8, then you need to take additional steps on reducing your cholesterol. And that's where there are other products like ezetimibe, or Ezetrol is the other name for it, or a PCSK9 inhibitor, which is an injection that can be once a month or once every 2 weeks. And these drugs really drop your LDL cholesterol, and they are very, very effective. Unfortunately, they're very, very expensive, and you need to meet certain criteria before insurance companies or ODB will cover them. Now, completely separate to this side of the equation, where they're looking at your LDL cholesterol, is triglyceride levels. If the triglyceride level is over 1.5, then these people should be considered to be put on Icosapent Ethyl. And that's the drug that I've been talking to you about here tonight, where the Canadian Cardiovascular Society has recommended this for anybody over 1.5 because it is very effective at reducing heart attacks and strokes. So these Canadian Cardiovascular Society guidelines, they weren't a wishy-washy recommendation. They were very adamant. This is a strong recommendation based on a high quality of evidence that people, not just people with known cardiovascular disease, but also diabetics, right here, diabetics with one or more cardiovascular risk factors. And again, it's going to be hard to find a diabetic that doesn't have at least one cardiovascular risk factor, which can be just being over the age of 50 as a male, or having high blood pressure, or having high cholesterol. And as I said earlier, for the diabetic population, almost all of them require a statin because they have high cholesterol. All right, so let's look at triglycerides as a marker of cardiovascular risk. So it's not just about LDL cholesterol. Right? This is the Copenhagen Heart Study, which looked at 96,000 patients, and they monitored their triglyceride level and their risk of having heart attacks or strokes or dying. And in all of these, you see that as their triglycerides got above 1, their risk of having a cardiovascular event went straight up. Now, if we look at, as I said, I live in Ontario. This is some Ontario data of almost 200,000 patients. And when they put together the data for the patients as their triglycerides were going up, the risk of having a coronary vascular event goes up as well. So once you're up over 1.5, you are at elevated risk of cardiovascular disease. All right, so triglycerides represent a marker, a red flag, if you will, for increased cardiovascular risk. Now, going back to the very beginning here, I mentioned that when I first said I had, or my doctor told me I had high triglycerides, he offered me a drug that's a fibrate. Fibrates will lower your triglycerides, but there have been many studies that have shown that although, yes, they lower your triglyceride levels, they have no effect on cardiovascular outcome. So it doesn't help you to live longer. It just makes your lab data look better. And recently at the American Heart Association, just back on November 6th, November 6th, 2022, which was 10 days before this video was made, there was a study called the Prominent study where they were showing a new fibrate called pemfibrate, and it did significantly reduce triglycerides 25%, but in the end of the trial it showed absolutely no benefit to reducing cardiovascular disease events or mortality. So I think that should be the final nail in the coffin. And if anybody is watching this video and they're on a fibrate, I suggest that they contact their doctor and go in and talk to them and see, do they really need to be on this fibrate? And if their triglycerides are high, which is probably why it was prescribed to them, then they probably should consider Icosapent Ethyl, which is very new, but has solid evidence that it does reduce risk of cardiovascular disease. All right, so the biological, clinical, genetic evidence very strongly associates elevated triglycerides with an increased cardiovascular risk. The lack of cardiovascular benefits in the trials of fibrates indicates that it's not the lowering of triglycerides that's important. Elevated triglycerides are merely a red flag that the patient is metabolically unwell, that they are in a state of systemic inflammation that needs to be looked at. All right, there's other drugs out there, niacin, which was used to lower triglycerides as well. Again, it may lower triglycerides, but it's not going to help you live longer. And the other thing are omega-3 fatty acids have been looked at for lowering triglycerides. A mixture of EPA and DHA is actually more effective at lowering your triglycerides. But the studies where they've used a mixture of omega-3 fatty acids, so that's EPA and DHA together, those didn't show any benefit in cardiovascular disease prevention. So it looks like it is just the EPA molecule. And in fact, when you add DHA to the EPA, you may be negating the benefits of the EPA. So you want to use a product that is just EPA. And the exception to these omega-3 trials has been that the trials studying EPA have all been successful. And there's been a couple. The JELIS trial was the first one that I mentioned. Reduce It trial is one that happened, and the results came out in 2018. And then again, November 6th, 10 days ago, 2022, there was another trial done called Respect EPA. That trial was run by the Japanese Heart Institute. It had nothing to do with a pharmacy company. It was just the Heart Institute monitoring 3,400 patients. The trial lasted about 8 years, and they came out with the same results as they did in the Reduce It trial, showing that high doses of pure EPA in a pharmaceutical preparation. So although the trial in Japan had nothing to do with a pharmaceutical company, they were using a prescription EPA to raise the EPA serum levels. All right, so let's look at Icosapent Ethyl. So the blue studies in this chart here are all the clinical trials that were done using pure EPA in the form of Icosapent Ethyl. And on the bottom in red are all the clinical drug trials that were done with combinations of EPA and DHA. And the big difference here is that the blues were all positive, the reds were all neutral. All right, so an important factor is that the serum level of EPA. So as I mentioned before, EPA is already in every single cell of your body. It's a vital part of your immune system. And in the REDUCE-IT trial, which had people from all around the world, the baseline level of serum EPA was 26, which is a very low level. When they were looking at studies like JELIS, which is a Japanese trial that I mentioned early on, with the 16,000 people that weren't particularly sick or unhealthy, but it showed benefit. Because it was a Japanese fish eating population, their baseline level, their natural level, was quite a bit higher than what we got in the North American, European populations that were studied in the REDUCE-IT trial. Pardon me. And there was a very large clinical trial called STRENGTH using 16,000 patients run by AstraZeneca, and it was a failure. And it was a mixture of EPA and DHA. They also had a very low serum level of EPA when it started out, but their formulation didn't get the serum level of EPA that was needed. So this is the newest piece of data that came out 10 days ago by the Japanese Heart Institute, the RESPECT EPA trial that I mentioned. And here you'll see that the first 4 years there wasn't much of a separation because it wasn't a large drug company run trial. It lacked the funding and the resources to get people in the trial quick. It actually took them a full 4 years to get the trial fully enrolled. And then, as you'll see here, from the beginning on, they had a lot of people that were dropping out. If you try to get somebody to stay in a clinical trial for 8 years, it can be difficult. So, but in spite of that, in spite of the low numbers here, there still was a statistically significant reduction in cardiovascular events. And so this hazard ratio of 78.5, that translates into a 21.5% reduction in primary endpoints, was the heart attacks. Down here it tells us cardiovascular death, fatal and non-fatal heart attacks. Over here was a secondary endpoint where they were looking at a few more events, and this here showed a 26.6 reduction in cardiovascular events. And again, it was statistically significant in spite of the fact that there were low numbers. So there's been more than just these clinical trials of a lot of patients that showed that it reduced the number of cardiovascular events. But I'll give you a bit of information about the trials that have happened. So this is the biggest one. This was REDUCE-IT. This was run by a pharmaceutical company in the US called Amarin. It involved 8,179 patients. It ran for 4.9 years, how long the average person was in it. And these are the numbers from the trial. So a 25% relative risk reduction in the 5-point MACE. So what that means is fatal and non-fatal heart attacks, strokes, emergency bypass, and hospitalization for unstable angina, chest pain. All right. So when you looked at the 3-point MACE, so here's where they isolated just the really definite black and white markers: fatal or non-fatal heart attack or stroke. Right? Those there's no ambiguity in those events. And when they looked at just those, there was a 26% relative risk reduction. And what that meant turned out to be is that for every 28 people that were on the drug, it prevented one of these major events: a heart attack or stroke, fatal or non-fatal. So when you're looking at the individual markers, it showed that there was a 31% reduction in heart attacks, 28% reduction in strokes, and a 20% reduction in cardiovascular death. And this is very impressive because even the cholesterol trial, Jupiter, did not show statistically significant reduction in cardiovascular death that was the trial for Crestor. So this is very impressive data. And for those of you who are familiar with statistics, when you get a p-value with this many zeros, that is outstanding. That means that the translation of that would be the chance that this data happened purely by chance is like 1 times 10 to the minus 7. That is incredible data for an outcome trial that lasted 5 years. So this is a very technical slide that we don't really need to get into, but essentially what we're pointing out here is that the subgroup that I have a personal interest in, which was the patients with high triglycerides and low HDL, they had a 38% risk reduction in cardiovascular events. All right, and this is to show you that when they looked at the different groups of their baseline cholesterols, it didn't matter what their level of cholesterol was, this drug worked. Okay, so this slide here shows that when they looked at the two groups, they separated all the patients into the ones that had normal triglycerides, so under 1.7, and those that had high triglycerides over 1.7, that these green and blue lines here are superimposed on each other. Okay? Following here, and that the placebo is the top line here. So what that means is that it didn't matter at all what the triglycerides were, whether they were high or low, the benefit was the same. Okay, and that's for the primary endpoints or the secondary endpoints. The difference is that when your triglycerides are very high, you are at a much higher risk. And so if you have a 25% reduction in your risk and you were low risk, then it's a small reduction of absolute risk. Whereas if you were at high risk and your high risk was reduced by 25%, that's a much bigger drop in your actual risk. So there is, I guess you would say, more bang for your buck. The higher the triglycerides, the more effective this drug will be, but it'll be effective to the same relative risk reduction regardless of what the triglyceride levels are. All right, so there was some concerns about bleedings. Part of the way that this drug works is it has effects on your platelets. But the key point here is there was no increase in significant or severe bleeds. Okay, and here I think it's important to note that in this patient population being studied, they were already on a lot of medications that increase bleeding risk. So antiplatelet drugs like aspirin or Plavix or ticagrelor, those are drugs that almost 50% of these patients in the trial were on at least one of. And then anticoagulants, so that's like warfarin would be the old one, or Coumadin. Nowadays they use products like Eliquis, rivaroxaban, which they're kind of the second generation anticoagulants. And so there was still quite a few, almost 1/4 of the patients were taking that type of medication. All right. Adverse events that were over 5%. Well, diarrhea and constipation. There was more diarrhea in the placebo and more constipation in the treatment group, but the placebo was mineral oil, which acts as a laxative, so I don't think you can get any data out of that. It's meaningless. There was an increase in atrial fibrillation. Okay, so and it was statistically significant. So atrial fibrillation, for those of you that don't know, that's when your heart's electrical system is a little out of whack, and the atrium is just going way too fast, and you may not be getting emptying of the chamber. And anytime that blood stops moving, it starts to clot. And so when you have atrial fibrillation and the blood can stop moving in the heart because it's not emptying the heart, you can form a clot, and then when your heart does return to normal function, that clot gets thrown into the bloodstream and ends up as a stroke. So patients with atrial fibrillation are, your main concern is that they may have a stroke. And as we've shown earlier in this presentation, there was a 28% reduction in strokes, and that was only in the first event of a stroke. So if somebody's in a 5-year trial and at year number 1 they have a stroke, then that's the end of the data collection as far as the events that you're looking to monitor. If in year 2 they have a heart attack and in year 3 they die, in the statistical analysis that we looked at here of 25% risk reduction, only that first event is counted. But if they were to take all of the events in the trial that happened, the total reduction in strokes was actually 37%. So yes, there is a slight increase in your risk of atrial fibrillation, but since your main concern with atrial fibrillation is that you have an increased risk of having a stroke, then you look at a massive reduction in strokes. It's a simple question of the number needed to treat versus the number needed to harm. And as long as the patient is stable in their atrial fibrillation, I don't think this should be an issue as far as whether or not to prescribe Icosapent Ethyl for somebody has a history of atrial fibrillation. All right, so let's go into look at some of the subgroups that happened in this clinical trial. So again, I just went and explained to you that the total events are different from the first events, and when we looked at the total events of the trial, the reduction was actually 31% reduction in events. So 1,724 events versus just the 1,185. In the green here is the first events that we had the original data from, where they just looked at the first heart attack, stroke, or whatever during that 5-year trial, and these other colors are further on. So there were some people in this trial that would have 4 or more events in that 5-year period. All right, if we look at just the US population, which more closely mimics the Canadian population, we'll see that there was a 31% relative risk reduction, and that they only needed to treat 15 patients to have prevented one of those primary endpoints of fatal or non-fatal heart attacks, strokes, hospitalization for unstable angina, or emergency vascularization. So that's a bypass or a stent. And when they looked at the secondary endpoints, the hard ones, as I said, just the straight heart attack, stroke, fatal or non-fatal, 31%, number needed to treat, only 22. So this is, the line's clearly separated, and the longer you take it, the bigger the benefit. All right, so again, if we look at the Reduce It USA population, here we see the breakdown of the individual endpoints, and unfortunately, because of my photo here, you can't see it, but total mortality was statistically significantly reduced 30% in this subgroup. All right, when they looked at the data and they tried to see where there was a correlation and where there wasn't, they found that the only thing that matched was the serum EPA levels. Okay, so when there was the scientific language here is just saying the reduction in event rates matched EPA levels. They did not match your non-HDL, which is like your LD, the particles of your cholesterol that is not the LDL cholesterol. Triglycerides, it wasn't relevant to triglycerides or ApoB. This is a marker of inflammation, and that's the famous LDL-C or LDL cholesterol, bad cholesterol. These events correlated to serum EPA levels. Okay. Here we have the serum EPA levels on this line here. So as the serum levels of EPA increased, your risk of having a heart attack or stroke drops, and to a point where here you're looking at almost a 50% reduction in your risk once your serum levels are over 200. And that was the same for the secondary endpoints. Very clearly, as your serum level increases, your risk of a cardiovascular event decreases. Okay, and just back this past August, Dr. Bott presented at the European Society of Cardiology on when they looked at all the heart attacks in Reduce It. It didn't matter what type of a heart attack it was, fatal, non-fatal, what's called a STEMI or an NSTEMI. The risk of having a heart attack clearly followed a straight line down of reduced risk as serum levels increased. Okay, let's look at the diabetes population. So here you see the red line is the placebo, the blue line is the diabetics. Unfortunately, the reality of being a diabetic is a cardiovascular patient on a waiting list. It's just a matter of time. Diabetics don't die from excessive sugar in their blood. They die of heart disease. So, in my opinion, you don't need to wait for that diabetic patient to start to have symptoms or see that it's obvious that they have cardiovascular disease. They need to start preventative therapy as soon as possible and slow the progression. Unfortunately, the Ontario government didn't see it that way, and they do not cover Icosapent Ethyl or Vascepa for patients who are diabetic without proven cardiovascular disease. And that's something I think the diabetic advocates need to jump all over, because that's just not right. And again, here when they looked at the total events of just looking at the patients in this trial who had diabetes, there was a clear reduction in events. Okay, so this is when they looked at the patients in the trial. How long did it take patients before they needed to have some kind of coronary revascularization, which is that they had a stent put in or they had coronary artery bypass graft, okay, a bypass. And you can see quite clearly that Icosapent Ethyl slowed down the need to have a bypass or stent. Okay, so in a summary of the data, you can see here that there was a 31% reduction in the total events. There was a 30% reduction in all-cause death in the US population, which mimics Canada. In the diabetic population, there was a 23% reduction in events with a number needed to treat of just 14. And in the revascularization, 34% reduction in the time to coronary revascularization, which is amazing. And all of these with extremely strong p-values showing that these statistics are very strong. Okay, so this is just a quick slide to show that no matter what the renal function is, it didn't matter. Okay, this drug is not affected by kidney function. And there were some more studies that were done where they were looking at the imaging, where they actually used the coronary artery calcium scan, the scan that I had to see that I had cardiovascular disease. And when they put patients on the drug and they took the CAC at baseline at 9 months and again at 18 months, they showed that the patients on Icosapent Ethyl actually had a reduction in the amount of plaque in their arteries, whereas the patients who were just on a statin, their plaque volume increased. And this is the vulnerable plaque. This is the plaque that tends to break off and go down and cause that heart attack. So what you're seeing here is a reduction in the plaque on the coating the inside of the arteries. And the reason that's happening is because your immune system is attacking that plaque. It's starting that inflammatory process to break down the plaque and get rid of it. Unfortunately, when it breaks it down and tries to get rid of it, if it breaks it free, you have a heart attack. When your immune system is restored to balance and you calm down that hyperinflammatory response, that plaque is allowed to stop being so inflamed, and it can be hardened you have a thicker fibrous cap over that plaque. And if you get calcification of the plaque, like I said, that's like putting bone over that plaque. It will stabilize the plaque and prevent progression of the plaque. But ideally, you don't get to that calcification level. You just have a thick fibrous cap. You don't allow any more infiltration of cholesterol into that area that gets inflamed and causes the plaque to get worse. All right, that's all I have for you. I hope it wasn't too much. And I just want to say that if you have any concerns about a family history of cardiovascular disease, I strongly encourage you to talk to your doctor about getting a lipoprotein A blood test done with your next cholesterol panel. It's a marker of cardiovascular risk from a hereditary point. It's a once in a lifetime test. You get it once, you'll never have to do it again. It'll give you an idea of whether or not you have a big risk because of your genetics or not. And then the other thing is if you're on that borderline where they really can't tell, maybe you're at high risk or maybe not, you got some risk factors but no signs or symptoms, then you can get a coronary artery calcium scan done, and there they will be able to look and see exactly if there is calcification of those arteries. And this will empower you to make the right decisions in your lifestyle so that you can reduce your chance of cardiovascular disease. For example, for me, when I was talking to my cardiologist and he was telling me there's no point getting the CAC because no matter what the result is, I'm not going to change what I prescribe you. And I kept trying to explain to him, it's not about him. This is about me. When I saw that I had plaque in my arteries, it motivated me to eat better, to exercise more, and to make sure that I was getting the optimum preventative therapy. And that included having this Icosapent Ethyl, which at the time was not available in Canada. And I used to drive down into the US, buy 3 months supply at about $1,000 US and bring it back because it was important to me to do everything I could to reduce my risk of cardiovascular disease. And so if it's important to you, please talk to your doctor. If you have high triglycerides, don't let the doctor brush it off. This is a red flag that needs to be addressed. All right. Thank you for watching the video. If you know somebody with cardiovascular disease, please share. Thank you.